day, even if it's helpful to you, that you can text her and say, "Hey, I just thought of this random question. What does the incision look like? Can I get an MRI? I ride motorcycles a lot. How does this work with my helmet? I swim, I cycle, I fish, all of those nuances of life that make life enjoyable. Being able to ask, like, how does a cochlear implant or a hearing implant fit into my lifestyle?" And she's able to connect you with others that are similar in age and hobbies and interest. And you can speak with them about what it was like to go through this. Because, like I said, as much as I know about implants, I do not wear one. And it's important that you do speak consistently to someone that has gone through this journey.
Yeah, and so there's something through the Dallas Hearing Foundation, and they call themselves the Dallas Cochlear Clan. And they have meetings. I'm actually speaking at one, I think in July. It's in Plano, at the police department, but they have a Facebook group, and it's people that are thinking about going through having a cochlear implant. It's also people that have gone through. So it's a great resource. And that is something I would like for y'all to, join that Facebook group, the Dallas Cochlear Clan. And they're really, really good about getting together and understanding the process, like what Erin said. Just because you have an evaluation does not mean you have to do it, but that's the first step. And then also talking to other people that have gone through the process.
Find that.
Yeah.
So
Since
how do we exactly find that page?
Let me I've got you, Gary, pulled up here, your chart. Let me just make sure. Is your email Gary7958 at sbcglobal.net?
Yes.
Perfect. Okay, I'm gonna have Cayden, my student, like I send you a link to the Facebook group, and also to is it Jackie Clark, I think is her name. She's
Oh,
really
Jennifer
helpful.
Clark.
Jennifer, I always say
Yeah,
Jack.
she's
Jennifer.
awesome. Similar
Jennifer
Jamie.
is amazing, but I'll email you. I'll have my student Cayden email you some of that information for you.
So since you guys are the only ones on here, before I provide any information, or even Allie's trying to hop on as well, what kind of questions do you have at this time? And it's okay if you don't have any yet. And you're like, I don't even know what to ask. Do you have any questions right off the bat?
Well, I've tried to do as much research in advance as I can,
Good.
and I don't, and so some of my questions I keep coming back to, and it part of it gets into the evaluation process. Like I
Yeah.
said, I saw Dr. Newcomer. He looked at my hearing. He said, "You need to be considering cochlear." And
Yeah.
so I set the appointments up, and I know there's an evaluation meeting. Uh, Obviously, I've had a hearing test, and they gave me one in Dr. Newcomer's office as well. And so they've done that part, and I know he said, well, your hearing's enough that we can certainly a candidate. He took it down to the Cochlear guys, they agreed. But as I look at things like what exactly goes on in the evaluation process. I'm going to have an MRI before, so they'll have that
Yeah.
information. But what all goes on? What are they checking for? And
That is
they
an
try to
excellent
qualify you.
question. Yes, I love that question. It's fantastic. So, one of the biggest things to understand is it's different than our normal hearing tests and audiograms. You've been wearing hearing aids for a while, you're familiar with the basic audiogram. We do speech testing typically. They test you in headphones or earphones, things like that. When you go into your cochlear implant eval, it is typically done with your hearing aids on and what we call the best aided condition. So, the purpose of the cochlear implant evaluation is to understand how you're functioning with your hearing aids on at a conversational volume. And so as an audiologist, when we test you in the booth for a normal hearing test, your hearing aids aren't on, and we're able to kind of blast you with some volume to help you hear the words, right? Not that volume means clear speech, but it gives you a better shot. So we could present that at a really high volume to get, let's say, for example, 60% is what you got on your words. However, when you go out into the world in your day-to-day life, you're wearing your hearing aids. While I talk very loud, for example, as an audiologist, I don't walk around speaking at 100 decibels like we would test you in the booth, right? And so the cochlear implant testing is done at a conversational volume with your hearing aids on to be more real world like. It is done in quiet. It is done with each ear individually, and it is done in background noise as well to create a full picture of how you function with your hearing aids. And sometimes there's also a questionnaire. You might have already done some of those, but like a questionnaire on your day-to-day life. Where do you struggle the most? Is it TV? Is it dinner with friends? Is it church? Trying to understand what areas we could potentially improve in with this technology. Yeah, really good question. Allie has hopped on now. I just want to introduce her and give her the floor for a moment. Allie, like I said, is our patient education liaison and called an engagement manager on our end. And she is an ongoing point of contact for questions you might have throughout this journey. She supports anyone that is looking into this technology and is interested in learning more. And she can kind of speak to why things are different than hearing aids, or why implants are different than hearing aids, how they work, what they look like, things like that. So I will let her kind of speak to her end of things. And for any of those on here, please feel free to interrupt at any time. We're an informal crew, so Paige and crew, if you guys have questions, feel free to ask. But yeah, we will kind of take it from there and just start kind of going through some of the ins and outs of why implants are different and what that looks like.
Hi guys, my name is Allie Castillo. So like Erin said, I am the engagement manager and I cover Oklahoma and North Texas, so Waco and up. Am I just describing my role just to make sure I have everything right?
Yeah, just a little about your background and how you kind of help support patients. And then, yeah, they're here to just kind of learn the basics.
Okay, perfect. So yeah, my role is very education based, and I come from an education background. That's where my career was pre-Cochlear. So I'm really here to make sure that any candidate and so family, friends, all of that, are fully informed, know exactly what to expect, know what Cochlear has to offer, and all of the resources we have to offer as well. Because I'm just stop number one. After me, we have what's called a recipient solutions manager, and they're going to be able to guide a recipient after they've received everything, surgery. They can help with processors, programming, things like that. So I'm here pre-surgery again, stop number one, and really just education based. I'm going to let you know how a cochlear implant works.
Values you feel every day.
And make sure you're being able, I guide you through that process. So provide you with extra information, whether that be digital, mail, or even with a volunteer. So we have a network of volunteers, recipients who are really passionate about their hearing and their hearing journey. And they love to connect with those who are in the middle of figuring out what they want to do next. And like just yesterday, I had an event in North Texas, and we had a volunteer come who has had a cochlear implant for, I think she said 38 years. She has both sides. So she's able to speak to that experience, both when she had that first side, as well as now that she has both sides. And our candidates were able to connect with them. When it comes to a candidate and volunteer connection, I make that connection. I introduce them, whether it be through email, phone call, text, typically email or text message. And then I step back, and candidate and volunteer can coordinate on their own how they want to communicate, when and where. I'm fully out of it. You guys get a really candid, what am I trying to say? Candid
connection. We also talked about the
connection. Thank
DSF
you.
meetings too, like as a place to converse and meet other people too. Yeah.
Yes. So that is another place again that you guys can connect with others who are also in that same steps in their journey. We have virtual events as well, bi-weekly at this point. They are national. So those who do my role in other parts of the country are able to connect with everyone, give information again about Cochlear, and then I'll connect with you if you're in my area and help you through that journey afterwards. I'm trying to think if I'm missing anything. I am bilingual, so anybody who speaks Spanish, I'm more than happy to help them. And try to think if I missed something. Erin?
No, that's a really good background. Thank you. And then I know someone else hopped on. I just want to take a moment to pause now that you've met Allie. And Gary, I know we answered one question, but I wanted to take a pause and see if you guys had any upfront questions, as well as it looks like Linda has hopped on. Does anyone have any questions? And we're happy to go through. Of course, we have, slides we can show you and videos we can show you, but I'm happy to make this more personalized. And if you guys have any more questions right off the bat, we can walk through those.
Just
Well,
that.
I'd like to go back on the evaluation.
Oh,
because
sure.
you talked about the hearing part, but what about the analysis of the MRIs and things like that to look for whether you're a candidate?
Yeah, those are really straightforward. So all they're looking at in an MRI is to ensure you have a cochlea and a nerve that suffices for cochlear implantation, as well as making sure there's no, they just look at your overall system. There's no tumors as the cause of your hearing loss, right? That would have to be addressed outside an implant. So just kind of like a very large overview of what they're looking at. Most people have very normal cochleas. Otherwise, if you have a big asymmetry or ears that are very different, that can be a consideration. They just kind of want to know what they're walking into in terms of surgery. Most typically for adults, there is very little contraindication from the MRI alone for undergoing cochlear implantation. Most of medical clearance comes from, are you eligible to undergo anesthesia? There is very little from an anatomical perspective. You've made it this far. Most anatomical differences come in children. That would be a contraindication for a cochlear implant. No active infections, of course, so making sure they're covering all their bases and looking at everything on the inside and looking at your cochlea and the nerve and just make sure everything is there, that we can put an implant in, right?
Would they typically look at both ears in that? Because I'm practically totally deaf in my left and partially in the right. And it's a question whether my left can ever be, it's never worked. And doubt whether they can ever get it going. But I think it should be looked at. And I'm just asking if that would be something they would look at as well.
And that is something they'll look at. Sometimes with adults, what we'll see is something called ossification, which just means there's kind of been bone or fibrous tissue that grows in your cochlea, and it could be a consideration during the implantation process. Now they have ways to kind of break through some of that, but what they'll do is look at that and see if anatomically there's an ear that's going to be better to implant than the other. And we'll combine that with the audiological cochlear implant evaluation and see which ear is the better candidate for the cochlear implant. And it can be difficult, right? Because sometimes the long-term deafened ear is the one we naturally jump to be implanted. But sometimes the other ear is the one will actually do better with a cochlear implant. So it really is very personal. very specific to you, and something that they look at as a team between the audiological consult and the medical consult. And like I said in the beginning, just because you go for the audiological portion and the medical consult, it does not mean you have to get surgery, right? It's just gathering the information so that you kind of have the best idea of what of expectations and what your journey entails.
All right. Thank you.
Yeah. Do you have any other questions? It doesn't have to be related to the eval.
Well, okay, if no one else is going to ask, I will ask.
Yeah. Until
All right,
if Linda has anything too, you can come off mute. But yeah, ask away. This is your time.
We're in.
Residual hearing. Will you lose hearing in your ear with the cochlear implant? Will you lose your residual hearing in that ear?
I would say so. It's important to understand this contextually because, for example, when I started almost 15 years ago, most people lost their residual hearing. Current state, I don't remember the statistics on it. There is a lot of surgeons will preserve hearing. And so it is always, I will say most surgeons will not promise it, but it is very regularly done that they are able to preserve at least some of the hearing that you currently have. They are regularly doing it, but you're unlikely to find a surgeon that's going to overpromise in that arena, but it is definitely routinely done these days.
Yeah, absolutely. I was talking to Dr. Peters. He's an ear, nose, and throat otolaryngologist. Yeah, he's fabulous at Dallas Ear Institute. And we were
Regularly
talking about how much, now they can preserve compared to Cayden. Cayden was just telling me when he got implanted. Well, I'll let you talk.
Yeah, so whenever I got implanted, hi, Erin, it's nice to meet you.
Hi.
I was implanted whenever I was 5 years old. I contracted bacterial meningitis, and whenever I was going through the surgery before, I was muffled hearing. It wasn't fully gone, but after they did the surgery, it took away my full hearing and just used the implant.
But now, like if you were implanted, in this day and age, you might have had some residual, that's very possible. So even though you were implanted in what year?
2007, I think,
2007.
20 years ago.
Yep. Technology and surgeons have made such progress. So that's why a lot of times we, with my patients, I say, hey, let's have a cochlear implant evaluation just to see, because technology changes so much, and things are just working so much better than what they used to.
Well, if I'm not mistaken, I think they can, you correct me if I'm wrong, Erin, you can turn on the sound now 2 weeks after surgery, correct? Or like 3 weeks, somewhere around that?
Honestly, it varies by facility. I think we're in the middle of a big shift, honestly. So you will see some people activate at 1 week. There are facilities that activate next day. That's kind of on the shorter. I think we're moving towards that. We're not there as a whole yet from a professional side, but the research does support, historically we used to activate 3 to 4 weeks out. The norm has now moved up to around 2 to 3 weeks is what I'm seeing clinically practiced. But I will say it's definitely, we're on the verge of probably moving that closer to between 1 day and 1 week. And because what we found was from a research perspective over many years, of course, is that there's actually no adverse events that happen by moving that time frame up. And in fact, the adverse event is pushing it out because they're without their sound, right, for a month. And what we found is for no real reason. And so we are UT Southwestern will typically activate 1 to 2 weeks as their very normal schedule. I know, Gary, you were talking about UT Southwestern. So for that example, yeah, that's become absolutely the regular. So that, and those guys are great at preserving hearing too. So you might have some of that, but you're not getting the full extent of your hearing until that happens. And just to level set, Gary, you might have heard this, Linda, you might have heard this as well. I just always like to level set on expectations. Day one with your cochlear implant. My mom was a physical therapist, so I always use the knee replacement analogy. I can't get away from it. I can't get a knee replacement and go to my first day of therapy expecting to run a marathon, right? Cochlear implants, as much as I would love for them to be a magic wand, they are not. They are a form of therapy. And it does require you to put in effort to get where you're trying to get in terms of speech understanding and just functioning in your everyday life with your hearing again. And so you'll work with your audiologist on day one. It might just sound really weird to you. And this is what I would tell my patients in clinic all the time. You're going to look at me like I'm a crazy person, but that sound will eventually become meaningful speech with practice and your auditory therapy. We call it oral therapy. And so oral rehab will help you achieve the goals. Your first goal might be going back to the knee replacement example. Your first goal with a knee replacement is not running a marathon. That first goal might just be walking 10 feet and back or whatever it is. I should know this because my dad just had a hip and a knee replacement. But your first goal is going to be simple. Maybe with your cochlear implant, it's wearing it 13 hours a day as recommended. We know that's the amount of time needed to reach optimal speech understanding. Maybe your second goal is having a one-on-one conversation in quiet with your significant other, right? You progress as you accomplish those goals to more complex and harder goals as you work through therapy and wearing it. But I do like to level set that it's on day one, people experience a large variety of perceptions on day one. Some people absolutely do walk away from that appointment hearing full speech. Other people absolutely walk away from day one hearing weird beeps that turn into speech later.
Erin, can I add something in on that?
Yeah,
It
please.
took me probably around 5 to 6 years to get actually comfortable where I wanted to be. So it took me about that long just to get to
Yeah.
where I'm doing how I want to, understanding speech better.
And also another comment, I went to a conference previously at in College Station, and there was an audiologist that spoke. Her son, he's in his 30s or 40s, just got implanted, and he acclimated like super fast. Like I think he said like a month. Or maybe a couple weeks. And he said, yeah, it did sound weird at first, but then, and he plays the piano, and I'm going to have Cayden email y'all his Instagram information because he's really cool to follow. But he plays the piano, and with his hearing aids before, he was not able to hear those notes, those super high notes. And now with his cochlear implant, he can. So it's, really cool. Like, back then that's how long Cayden took, but things are better now.
Way better.
Mm-hmm.
Yeah.
When I say I love that you said he can hear those higher notes. Yesterday, I was just with a patient.
I was just going to ask if you could speak to what you were doing yesterday.
So yesterday, a colleague and I went to the activation of a patient. She is almost 100 years old. She'll be 100 next month. And she and her audiologist really talked about it. Like, do we want to do this? Because I know people, sometimes age can stop them. I have people who are like, well, I'm in my 60s. And I'm like, I had a 99-year-old. So, so she'll be 100 next month. She was getting activated. She was very excited. And a comment she made was, I thought my voice was more soprano, but it's much more alto with my cochlear implant on today. And so it was really interesting that she was getting those higher notes. She said she heard a little bit of whistling or a little bit of beeping, but was really excited about how it was sounding, and that she can start to practice and get ready for her birthday party that they're going to have next month with her family. And So it was really amazing to watch her. She was so excited about it. And she put it on. She actually chose the off the ear option, which is called Canzo 3, because she didn't want something extra on with her glasses. But she's super excited, plays bridge multiple times a week, and is excited to practice with her cochlear implant, and did acknowledge, sounds a little bit funny, but was not uncomfortable. And we also mentioned that next time she comes in about 3 weeks, she'll probably want that volume raised. But yeah, so she was immediately saying, my voice is higher than what I thought it was. I thought it was deeper. So she was awesome. I'm happy to answer more questions about her. Just so exciting. Anyways, that's all.
It's a great point. Age is not a contraindication in cochlear implants. It's also another great point, to Cayden's point as well, of every person's goals in life are different in terms of their hearing, right? And so you could have someone that's 5 years old, what they need out of their hearing when they are 5 is different than a 30-year-old, right? Maybe they hold a corporate job and they're going to a kid's soccer game or their own soccer game. Bless them. Maybe their knees still work as a 30-year-old. Mine didn't, and their needs from their hearing are different than a 50-year-old or a 70-year-old. Maybe you are a 70-year-old, you are going to yoga classes, you're going to sporting events, but also maybe you're a 70-year-old that prefers to stay home and have one-on-one conversations with friends. Maybe you watch TV. Those lifestyles look different, even though the age is the same. And so those goals can be very personal and specific to yourself. And so how long it takes you to achieve your personal goals and what you deem as a success, you'll work with your audiologist on. But I would say from an objective point of view, when we talk about booth testing, objective testing in the booth, we typically see, and this has changed too over the years, is that we typically see people outperform their hearing aids by at least 20% within the first 3 to 6 months. That's a very conservative statistic, but a very common one. So that's kind of from an expectation. It is still at the end of the day an aid and a therapy. It is not meant to be perfect or give you supersonic hearing, but it's definitely meant to be an improvement over your current technology.
Now, how do you mean 20% improvement over your hearing aid? In what sense?
Yeah, so if we talk about just objective testing, like when you go to that cochlear implant evaluation, let's just pretend one ear is at 0% on your sentence testing. Like you got 0 of those correct. And then the other ear, let's say maybe you got 50% correct. And let's say the 0% ear was implanted. This is just an example. The expectation objectively in terms of norms would be that ear would be performing. Maybe you get in 3 to 6 months, maybe you get 20% correct on that ear. Is that 100% meaning you're understanding everything that's coming into that ear at 3 to 6 months? No, but it means that you're doing better than you were doing before.
So
And that's really
you're talking word understanding and word comprehension, which is certainly a big issue. I agree. So.
Exactly. And it comes down to the testing involves sentences. It involves sentences with background noise. It involves words, even broken down to what we call a phoneme, which is not important to you other than it discriminates different sounds. So maybe like Allie's point, the high frequencies are very commonly the hardest thing for people with progressive hearing loss to obtain, even with hearing aids. It just can't get us to where we need for good speech understanding. And so oftentimes, and you see you nodding your head, it might be, I can hear things, but I can't understand. People sound like they're mumbling constantly. And they're typically not, although I will say there's lots of people in this world that do mumble. But Overall, the high frequencies give us clarity of speech. And to get those back, we do have to have that cochlear implant that's helping us get us there when we're past the hearing aids being able from a power perspective. And then once we have access to those high frequencies again, our brain can relearn to interpret that information that works towards clarity of sound again. It doesn't happen overnight, but that's what I'm talking about in terms of sentence and word understanding improves with time. And that's really what we're looking at. And I say it objectively because that's you inside a booth on paper. And then subjectively is how you feel like you're doing with your daily goals. Maybe conversations between the two of you, how you feel like those are going, maybe listening to the TV. Those are types of like functional goals at home that you will work with your audio, work on with your audiologist. Does that make sense?
Yes.
Yeah. Allie, do you have any like how it works to show how have you guys seen how a cochlear implant works?
I have not.
Okay.
Yeah.
While she's pulling that up, I think we can share screens on Zoom.
I was saying, can I share my screen? I know I'm an attendee, so I didn't know if I had that access.
I don't either, but we're going to try access. If not, we can put it in the chat and y'all can share. But while she's pulling it up, I'll kind of talk through it. You might know this already, but a cochlear implant has, of course, an internal portion, right? The part that they put in surgery. For reference, it is an outpatient, relatively easy surgery. These guys are very talented. And so typically it is a 1 to 2 hour outpatient surgery. You go home same day. People that do a lot of heavy lifting typically return to work after a week. But for most day-to-day normal life things, it's 3 days. Yeah, Paige.
Okay. You guys should be able
to share her screen.
Oh, yes, we can see your screen.
Okay, perfect. So as Erin was saying, it is an outpatient operation. It depends on the person. Definitely talk to your surgeon on how soon they think you'll feel good. I have people want to take a week off. I have a guy who went to work the next day. That isn't normal, but just the same, everyone feels a little different. So the cochlear implant is going to sit underneath your skin. It's number 2, and on top of that bone. Is Dr. Peters your surgeon, or you don't have one yet?
You're going to UT Southwestern.
Yeah. Do not have a surgeon. I don't have one.
Okay, no worries. We mentioned that name, so I just wanted to check. So the cochlear implant, again, underneath your skin, on top of bone, and one of the electrodes is grounding, and the other will go into your cochlea, and it will wrap in your cochlea. I have another picture as well, and it will hug that nerve. So it will look a lot like this when inside your cochlea. All of those white dots, and I'll zoom in for you, are touch points. There's 22 touch points to your nerve to be able to activate different frequencies depending on who's talking. So Gary, right? Is that your name, Gary?
Yes.
Yes.
Perfect. And then with Gary, who is this?
Margaret.
Margaret. Okay, perfect. So Gary, Margaret's voice will likely stimulate those higher frequencies, while maybe your friend's voice is going to stimulate those lower frequencies. And you can think about it like a piano. What needs to be stimulated, what keys need to be played, will be played. Everything's not going to light up at the same time. It's going to be relative to what's coming in. But it's going to allow you to get that wide range. So maybe you don't currently hear your refrigerator running, but you might hear it now when it's stimulating those frequencies. We have a volunteer who did mention she kept getting annoyed at home after being activated. She was like, what is that sound? And it was, in fact, her refrigerator that she hadn't heard for 20 years. So the AC might drive you a little crazy at first, and the refrigerator, eventually you'll tune those out. But you'll get all of that range of sounds. And again, it's going to hug into your cochlea and stimulate with electrical impulses. That's what these little guys are showing. So that's where that sounding kind of funny might come into play. Rather than stimulating hair cells, which is what's currently happening for you, those hair cells aren't working like they used to. We're going to bypass those and say, we don't need you. We're going to go straight to the nerve. Questions about that?
No, just
Here's another image.
no. I think I understand that, but
Perfect.
So the picture you were showing was the nerve?
Yeah.
Okay.
Yes. Yep. This shows the nerve. And Linda as well, since you're sitting on here, I can make sure I have both of your emails before we leave, and I can actually send you the candidate guide, which has this in it as well, if you would like.
That's great.
Perfect. It's pretty dense. It's got a lot of information. It's really good. This here is what the implant itself looks like. There's the magnet here, the chip, and the electrode. It's a little hard to see, but it's curled, so it goes right into that cochlea. And you're safe to get an MRI with this implant. You're good at 1.5 and 3.0 Tesla, which are the most common. There is no limit. You can get as many as you need.
So which is the part that goes on the outside of your ear?
Yeah, all of that's inside.
All of that. Okay.
Mm-hmm. The outer part has two options. This is the side view. We'll go down here to my people. These are the pieces that go outside. There's one that sits on the ear called the nucleus 8, or one that sits off the ear called the canzo 3. I do like to let people know, if you're a hat wearer, if you like to wear hats a lot, you'll probably like the nucleus 8 a little bit better. The canzo 3 is a little bit thicker because everything is in one piece. We've got microphone, battery, magnet, as opposed to microphone, battery, and magnet, or magnet down here.
So on the top picture,
yeah,
the part that you see on his bald head is what?
It's the magnet.
The magnet. Okay. And there's something over his ear also?
Correct. Yes. Let's see.
So
It's a little bit, I'll see if I can find a better picture for you.
Oh, sorry.
So go for it, Erin.
I was just going to say, for reference, I forgot to mention, my fault, is they are magnetically retained. So that internal piece has a little magnet in it. And then the external piece sticks with a magnet. So if you use the one that's over the ear, both are rechargeable, but the one over the ear kind of has a piece that looks like your hearing aid, but there's nothing coming down and going inside your ear. It's going to be like a little string with a magnet that connects to the internal. And then, like Allie said, the lower version, everything is encased into that circular disc. And so the rechargeable battery, the magnet, everything, it's a little bit thicker of a device. And that's why we say, if you're a helmet or a hat wearer, that top version works a lot better because the magnet portion is slim and it can fit right under a hat or a helmet. The bottom one is one that's just used. A lot of people, maybe if they wear glasses, sunglasses, and they want something completely off of their ear. Both of them function the same in terms of outcomes. So you're not losing anything by choosing one or the other. They both have the same chip inside. And you can actually, if you get to the stage of scheduling surgery, you can work with your audiologist. You get 2 in your initial kit. So you could choose one of each to start out with, and you have the first 90 days to figure out if you want to trade one out for the other one. So, like, for example, let's say you got one of each and they have different colors, as a fun fact. And you say, man, I thought I would like the one off the ear, but but I actually really like this kind that sits on my ear. In the first 90 days, you have wiggle room, and you can actually just trade out your other one for two of the one that sit over your ear, or two of the one that sit off your ear. So you have a lot of flexibility in those first 3 months to figure out what works best for you as you start wearing it. Because even though you're learning about it now and you think you might like something, or you think you might like a certain accessory, once you start wearing it, you'll figure out what's actually working best for you and your lifestyle. So just to mention, there's a lot of flexibility. Don't feel like, it's a very permanent decision in terms of the external portion. The inside portion is permanent. But the external portion, you have some flexibility in choosing.
So the magnet fits underneath in the receiver, I guess, underneath your scalp, and that won't change. That's the same regardless.
Yeah, and that's you bring up a really good point, is the part that's surgically implanted on top of your bone there, and into your cochlea. That is a device that we plan on not having to be replaced. So Cochlear, we make sure all of our external devices are retro compatible. So for example, our patients back from like the 80s that got implanted, or early 90s, those older implant patients inside are actually still able to upgrade their external portion to new technology. So Cochlear is a very strong believer in making sure that older technology inside has the capability of upgrading externally. And that's really existed as our gold standard for as long as we've been around. And not that we're going to get into the nitty gritty of it today, but we actually, the new implant just came out in the fall that actually has an upgradable internal as well. And so now you have an implant that's going to really be able to keep up with you over time. That internal chip actually has upgradable capabilities for the first time in the cochlear implant world ever, which is really, really, really cool. So you will have the ability, this is called the Nexus system. The internal has an upgradable chip, and the external pieces are upgradable over time as well, kind of catapulting the abilities over time, longer periods of time. Just something worth mentioning, because we've never had that. Nobody's haven't had that in the cochlear implant space, the ability to truly upgrade an internal chip, which is neat.
Agreed.
Is the magnet removable? I mean, like if you have to wash your hair, what do you do?
Yes. So the external piece, you'll take off at night and put it in the charger. I'll show you the chargers real quick. If you're asking about the magnet on the internal piece, it is removable. Erin may have heard more than I have. It's very rare to need that magnet removed. It's surgical, very small incision, but you can if you needed it. On the outside piece,
I'll touch on that, because it's important to know it is removable internally, but rarely do we see that's the case. Cochlear chooses to make our internal magnet removable. It's in like a little, I'm not going to have a good document camera because I never show these, but I have a dummy one right here. It sits in a little pocket. You're probably not going to be able to see this, but Allie can show you a follow-up video. And the magnet just pulls out. It just sits in a little pocket. So the only time as an adult I ever see the need for an internal magnet to be removed like this is if something comes up, and it's like head and neck cancers, right? Something where you're going to need monitoring very closely for a finite period of time. So like I've seen, for example, someone come up and they have come up with a head or neck cancer, and they need to be monitored for X amount of time, 6 months. They actually go in and remove the magnet, because a magnet creates a shadow on an MRI. So even though it's safe to go through an MRI, they can't maybe see everything they want to see from a head perspective. And they just remove it for those 6 months. They wear their implant on a headband, the external piece. And then when that time period is done, the surgeon goes back in with the little incision and just puts the magnet back in the pocket. And the reason that's important is because we wanted to make sure the technology is accessible throughout a patient's lifetime, no matter what. So the external portion, like Allie was saying, is just a simple, like truly like it's a magnet to your head. So you're just going to take it off when you sleep. We call it eyes open, ears on. So if you wake up in the morning, you plop it on your head, you take it off at night to go to sleep, and put it on the charger. And then the internal magnet technically is removable just for your peace of mind, but it's rarely ever removed in practice.
Here, I was going to show you it real quick. So here's my implant.
Perfect.
And you can just pull it off just like that.
Yep.
Yep.
Yeah. Oh, yeah.
Great. You have a perfect demonstration.
Yeah. Same on my left side right here.
Okay.
Yeah.
Both sides. All right.
And that magnet on the external piece is also changeable. So depending on where you are in your implant journey, you might need a stronger magnet at first, a weaker magnet as everything is healed and swelling goes down. So that magnet is very easily changeable. Like Erin said, eyes open, ears on. You can put those on the charger to go to bed. For Cochlear, depending on the battery you have for the over-the-ear processor, this guy, we have 3 batteries. I suggest either the one that lasts 16 hours or one for 21 hours. This guy here lasts 21 hours. And super easy to charge as well. These are what the batteries look like. This is the charger here for the off-the-ear processor. You open up the box, put it in, close it, it charges. As for the other ones, we call it the Y charger. There's little, not prongs, but kind of like prongs that match together. You twist it on and off. So both very easy to charge. Takes about 4 hours for a full charge. And then here is the difference between the different batteries. So the compact only lasts 10 hours. Personally, I don't suggest it, but it's an option. The power compact is going to give you 16 hours, and the power extend is going to give you 21. For us, our default right now is power compact. I tell people you get the biggest bang for your buck when it comes to size and battery life. But again,
And how long was that?
16.
16.
Mm-hmm. And like Erin said, you'll get 2 processors. So you can order the same, 2 same ones, 2 different ones. You can order different colors. And then you have those 90 days to decide what you like. And like she said, if you like them both, you keep them both. You can interchange them for different things. But you'll get the same sound quality from both and the same features.
I'm confused about the picture of the guy with the bald head.
Uh-huh.
He has a magnet and the earpiece.
Correct. Well, she only has just the piece. So again,
Okay.
this one has everything in essentially like a button. It's a little bit thicker, while this one has each of those pieces when it comes to microphone, battery, magnet, all separated. And so that's why it looks the way it does.
So the magnet that's on his head still needs to be recharged, or what about?
No. The only piece on that you take off is this longer piece here, shorter
I see they're
piece.
connected. Okay.
Yeah, you'll just twist that guy right off and put it on, twist it onto this charger here. This magnet just stays. Don't do anything with it.
One of the complaints I have read about regarding the magnet, the one you just put on your head, has been that it falls off sometimes rather easily. And I've heard mixed, I read mixed opinions. Some people say, no, it hadn't been a problem. It sounds like you can control that with the magnets. If it's falling off rather easily, you can get a stronger magnet then. And
you can. And we have something as well called software pads. You can also get like moleskin at Walgreens. It will change your magnet to half a step. So if 3 is too strong, but a 2 is too weak, you can put that software pad on your 3 and it'll move it half a step down. Also,
I will say, I will say too on that, Gary, it's very valid, and it does come down to mixed bag, right? Because it depends on my lifestyle as well. They are magnets, right? So even if you have the strongest magnet, you have to remember that we can't all just wear the strongest magnet. If it's too strong, you could have complications of skin breakdown. Remember, these are magnet on the outside and magnet on the inside. Your audiologist will make sure your magnet size is enough to retain and not fall off. And, it shouldn't fall off while you're walking around. But it can't just be the strongest magnet, because you can actually get skin and tissue breakdown, and that's unsafe. And so I will absolutely say, part of that first 90 days is understanding if that off the ear is going to work for you. If you are a gymnast and walking around doing cartwheels, the off the ear might not be the best option for you. And maybe it's just annoying, because there's also lots of kids that wear the off the ear with like the little clips that go in their hair that keep it on, and they love it. I don't know. It depends on, whether you're going to want to clip something from a safety line perspective to your head. But that's a very fair and true. Not everything on the internet is true, but that is a true one. And that some people, it does fall off, and it's not the greatest option for them and their lifestyle. And that's why I say that 90 days, figure out which one you like. And it might be two of the kind that sit over your ear for better retention. And some of that is how thick your skin is. Some people with really thick skin between the internal and the external, by nature, they're going to need a stronger magnet, or people with really thick hair. Some of those are outside of the control of just getting a stronger magnet. And so it might just be that you wear that top version, that 2-piece version or connected version. And neither one are right or wrong. It's just simply a preference. But because it is a little thicker and it doesn't have a piece sitting on your ear, I would always tell my patients, because even if someone goes in for a strong hug, right, they could knock that off. It's a magnet, and it's going to get knocked off. So you want to be able to wear a safety line, whether it's clipped to your shirt or in your hair, so that if it does get knocked off, it's just dangling on. Allie has the pictures up now. And so it's truly a matter of lifestyle and preference.
For both styles, there's retention options depending on what fits you. Off the ear has, again, hair clip or shirt clip, headband even, as well as hair clip or something to hug your ear if you prefer for that on the ear option. So, but again, it's going to depend on where you are in your journey, what magnet strength you need, what ends up working for you. And I tell people as well, keep in mind, listen to yourself. If you think it hurts, you could be too strong. So don't just think, oh, it'll go away. If it's hurting, listen, and we'll change out that magnet. It's pretty easy. Your audiologist can do it, or you can do it at home. Questions about that?
Paige, I know we're running out of time, I think, here on this. Please let us know. Allie can connect with you through email to give you more resources, or even have extended conversations. I think you guys have some really good questions, so I would encourage you to do so. But Paige, do you have any questions or anything we need to still cover? I know you said you had maybe questions from a patient that couldn't join. I want to make sure we get everything covered for you.
We did answer that. It was for the MRI. They said, can we still have an MRI after the implant? Do we have to, how does that work? And so y'all answered that, yes, you can still have an MRI. And
beautiful. Yep.
I've got here till, I don't know if y'all have an appointment right after this, but I've got till 12:15 open if y'all want to continue.
Okay, wonderful. And I was going to say as well, I'm sure Paige has all of your information. If you don't mind letting her know your preferred mode of contact, whether that be email, phone call, or text, she can share it with me through email, and I can contact you, send you information. Assuming she does that and I call or text you, please know I have a Denver number. So 720 will show up. It is real. It is me. So I like to warn people, it does not look safe in Texas.
And
So-
Allie supports
Correctly.
patients. Oh, sorry. Allie supports patients across the Metroplex, so she's very familiar with UT Southwestern surgeons and audiologists and DEI surgeons and audiologists. So she can answer a lot of your questions as you move through the journey, even if you're trying to figure out like how to schedule the appointment. Do you have a follow-up? Some of that stuff that there's just the journey can be quite demanding on the front side, and so having a hand to hold can be helpful throughout that's been through it.
So who do you work for? Who do each of you work for? You?
I work for Cochlear.
Yeah,
both of us do.
You both do? Okay.
Paige works for Total Hearing Care, of course, and for Dr. Gainey. Sorry.
And Cayden's my apprentice, he's got Med-El implants. Because there's 3 manufacturers of implants. So, and I think at Dallas Ear Institute, they let the patient review different ones and let the patient choose.
And UT Southwestern will too as well.
Okay.
Yeah, they will. And well, we'll just leave it at that.
And Gary or Allie, if you want to call up here, Gary, I can give them your email address if you want, or your phone number.
Do.
Perfect. I'll do that. Allie, the phone number to call up here is 214-987-4114. And Linda, if you want Allie to have your information, you can just call up here, say yes, give it to Allie. We can send it on over to her. And also, before we forget, I want to announce the winner of the gift card, and it's Gary Nicholson. You won the gift card.
All right.
Outback Steakhouse.
Great. Thank you very much.
So, Gary, you can call up here. You can swing by the office and pick it up. I think they can even mail it to you. So, you just call up here and let the office know how you want your gift card.
Okay. All right.
Okay.
Get the number for there.
Thanks for having us, Paige.
I know that.
You have it. Okay.
Absolutely. And Allie, just call up here and my front office staff will get you Gary's information. And Linda, if you want them to have, want Allie to have information, just let us know.
Gary, do you prefer phone call, text message, or email?
For just general communication.
Mm-hmm.
Probably not phone call. I'd say generally email, but any of them work fine. No.
Perfect. I will email you here shortly. I'll also send you a link if you want to meet with me individually. We can go a little bit more in depth. And I'll also send you that candidate guide that I talked about that has more and deeper information. And we can talk about where in the process you are. It never hurts to get lots of education, says a former teacher. So I'm happy to help and spend as much time as you need. Linda, as well, just let Paige know if you would like your information shared, and I'll contact you too. So
okay.
For reference, it's just for Allie to contact you.
Yes. If you tell me, please don't call me again, please don't email me, I won't. And if I contact you 3 times and you don't answer me, I will also leave you alone. So I'm not going to hound you too hard.
He's really just there to support you as you move.
Yeah.
So as you need.
And if you end up needing, I know you're at UT Southwestern, let's say you're like, actually, I need something different, I can always send you clinic suggestions. So, and if you want support group resources, I'm happy to send you all that. So.
All right. Okay. Well, thank you very much.
I appreciate you guys.
Reach out.
Yeah, thank you so much. This
helpful.
was great. So informative. I love it.
Good.
All right.
Good.
Well, we'll see
talk
y'all
to you
around.
later.
Take
Happy
care.
Wednesday.
Thanks, Paige.
Thank you.
Yes, thank you. Bye, Gary. Bye, Linda.
Bye.